are common, so that it will be useful in your day-to-day practice. So, as you know, the mortality among neonates are very high. Of course, sick neonates we may lose in no time. Early detection and appropriate treatment can save many of them. If you do not have facility, as Professor Srinivasan said, refer to somebody else to do a better management. So it's always important either you treat or refer at the appropriate time so that mortality and morbidity can be reduced. So whenever we see a newborn, we have to decide whether the baby is looking well, whether the baby is at waist, or whether the baby is sick. A well baby does not mean he does not have any risk factor. He has less risk than other people. So a baby who is born normally, cried immediately after birth, having a birth weight of at least 2.5 and above, who can breastfeed from the mother, who can maintain temperature, you normally take is a well baby. An at-risk baby is one who is born to a high-risk mother, or the previous baby they might have lost, or some problem may be there in the previous baby, or it may be a preterm low birth weight baby. He is obviously at risk. But you may also have a baby who is sick, who may require urgent and immediate management, like a baby with severe birth asphyxia, a baby who is very preterm, below 33 weeks with respiratory distress. Some of the babies, of course, may not have respiratory distress. Any major congenital anomalies. And as you know, intrauterine growth restriction is a major risk factor for the future growth and development of the baby. You can also have change in the color, activity, feeding, breathing. So you should be able to identify a baby who is sick from a baby who is less sick or do not have any obvious sickness in the baby.
Excuse me, sir. Sorry, sir. Can you just go to the PowerPoint show mode, sir? Be better, sir.
You're not seen well?
இல்ல sir. Slide show. மேல slide show போங்க sir. டாப்ல இருக்கு பாருங்க sir. Slide show. அது இல்ல sir. இங்க பக்கத்துல. ஹோம் பக்கத்துல sir. அப்படியே வருது பாருங்க. அதே ரோல்லே.
Home is there.
அதுல 5th sir. Slide show. Slide show sir. Next sir. Next. Next sir. Next slide show போங்க sir. Next one. Animation பக்கத்துல sir.
இந்த பக்கத்துல animation அடுத்தது in between review and animation.
Slide show. Yeah, that one sir.
Okay.
Yeah, just click.
Yeah. From current slide போடுங்க sir.
Is it better now?
இல்ல sir, இங்க போய்ட்டு மேல அந்த
current slide இங்க பாருங்க current slide ன்னு.
அடுத்த ரோல்ல sir. Right at the top from
beginning it's written there, no?
Stop sharing in there.
Current
அதை click பண்ணுங்க sir.
Yeah.
Okay. Yeah. Now it's better. Okay. So a baby who has got poor activity, poor sucking, he may have fever or hypothermia. Normally, a baby with infection, if his term may develop fever. A baby who is sick and preterm may develop hypothermia. So both are dangerous. Baby may have difficulty in breathing, convulsions, or jaundice, which involves the extreme extremities of the baby, or he may have bleeding from any side, abdominal distension with or without bilious vomiting, and central sinuses. Central sinuses may be normal immediately after birth, but once the oxygenation improves, the color should change. So these are some of the signs which are dangerous and immediately will require attention. Now we'll take up a few cases. A mother delivered a baby with gasping respiration. Obviously, they did not anticipate any problem. So first and foremost, we should think whether we have missed something. So you may have a baby who is term with clear liquor, but he did not cry at birth, he did not breathe. Or you may have a term neonate with meconium stained liquor and non-vigorous at birth, or a preterm baby with clear light, but he did not cry at birth. So you may have a preterm baby, you may have a term baby with or without meconium, but obviously he is not breathing. There is some serious problem. So last session, we had on the neonatal resuscitation. So as soon as the baby is born, we should look at whether the baby is having breathing properly or not, crying, whether that is a term gestation, and whether it's a good muscle tone. If all these are good, then the baby need to be dried and given to the mother or put on her chest for kangaroo care and breastfeeding. If does not have, the baby require resuscitation. I will not go into the details of resuscitation. Of course, initially you establish airway and breathing. If it is not improving, you go for cardiac compression and medication. But you must remember, a baby does not obviously have very high oxygen saturation immediately after birth. So gradually it increases. So now we say about to monitor the SpO2 and resuscitate the baby. Even at 10 minutes, a newborn will have only about 85 to 95% saturation. So don't be in a hurry to make the baby pink. Earlier we used to say give 100% oxygen, make the baby pink, and then you start reducing the oxygen. Now we are going in the reverse direction. So in term babies, we resuscitate with room air or oxygen. Now we are starting with the room air, and gradually you increase till the baby is saturation improves. So always it's better to monitor the saturation and then increase the oxygen level of the ventilation. If despite effective ventilation, there is no increase in heart rate or increasing, then you try to increase the oxygen and we go for the other steps of resuscitation. But when you come to the preterm baby, it's always better to use blended oxygen because there is always a risk of causing oxygen toxicity. So oxygen, we thought it is very good, but gradually we realize we may cause more problem by giving more oxygen. So as we discussed earlier, we may start with 25-30% and gradually increase. But if you do not have blended oxygen, then it is better to start even in preterm baby with room air and gradually increase the saturation. Now, the question of endotracheal suction, oropharyngeal suction, what to do. So when we were students, they say that don't allow the baby to breathe if the mother is has meconium state like that. Hold the chest and prevent breathing, suck the mouth, suck the pharynx, and if you think meconium endotracheal suction, then only allow you to breathe. I don't know how many babies lost hypoxia. Now the concept has changed. So you need not have to do endotracheal section routinely, whether thin meconium, thick meconium, whether the baby is vigorous or not vigorous, because meconium aspiration occurs before you realize it has gone into the chest. So it's very difficult to remove the meconium. Only when the meconium blocks the airway, you need to put in endotracheal tube and try to do the suction. Otherwise, only clear the airway and allow the baby to breathe. There is no need for putting endotracheal. You may do more harm than putting the baby. Now, we go to the next one case scenario. A baby is having a respiratory rate of more than 70. He's got grunting, chest restriction, and cyanosis. Obviously, he has got respiratory distress. Now, the problem comes whether this baby has got pneumonia, whether it's got a hyaline membrane disease, or a meconium aspiration, or some congenital malformation. So, whatever is the cause, initially our aim is to ventilate the baby or to the oxygenation, prevent, treat the shock. And if there is a risk factor for infection or sepsis positive, then you start on antibiotics. And if the baby has got a lot of frothing from the mouth, the saying is negative, then you may consider there is a tracheoesophageal fistula, which you might have missed, and you pass a catheter. Sometimes you may pass the catheter, but still there may be tracheoesophageal fistula if it is side to side fistula is there. So this is a baby with the chest retraction, where you can see the indrawing of the chest in a newborn baby. I always tell my students that the abdomen of a newborn should be a Ganesha who is fasting. It's not bulging, but it's not be empty. Here you see a newborn with the empty abdomen or the flat abdomen gone down, what we call the scaphoid abdomen. which indicates probably the baby has got a diaphragmatic hernia. If his heartbeat is on the right side, obviously 99% you are having a diaphragmatic hernia case. Of course, with antenatal ultrasound, many of them are recognized now before delivery, but sometimes it may be missed. Here you see the catheter is coiling, indicating there is obstruction in the esophagus. So it's a case of tracheoesophageal fistula. All cases of diaphragmatic hernia may not be so obvious like this case, where there are all lobes of intestine in the abdomen. You do not find the diaphragm on the left side. So it's an obvious case of diaphragmatic hernia. Earlier, immediately they would be taken for surgery, but now the present concept is that stabilize the babies first, improve the oxygenation, improve the circulation, and then after that only surgery. Now, next case, a preterm baby, 32 weeks gestation, minimal respiratory distress at birth, 12%, but we could feed the baby. But on the second day, he started developing apnea. So, apnea, by definition, if baby starts breathing, obviously everybody knows, if a baby does not breathe for 20 seconds or less than 20 seconds with sinus bradycardia, we obviously call it as apnea. So apnea in a newborn could be primary or secondary. Primary means it is the central respiratory is not working well with him, or he's got central apnea. Whereas secondary, some other cause, there is other primary cause in a baby. Or other way of classifying, central, mixed or obstructive apnea. So any type of apnea can be there. Whatever apnea is there, it is dangerous, but the treatment differs. So whenever you see a baby with apnea, we should see whether there is a temperature problem, sometimes hypothermia could be there. There could be blood sugar may be low, hypocalcemia could be there. So electrolyte imbalance can be there. There could be septicemia, anemia, meningitis. There could be multiple causes. But the fact remains that we should look for cause for apnea in every case, and if there's a primary cause, we should treat the primary cause. And in those cases, giving respiratory stimulants may do more harm than good to the baby. So you stimulate the baby and position the baby. Generally, what you do is mild extension of the neck and remove any secretion. Stimulate and see if it does not respond, then you give ventilation to the baby. This is what you manage initially. Then, if there is no primary, the secondary cause, or there is some other cause for apnea, you may give respiratory stimulants. You may give aminophylline or caffeine. Both are equally good. See, you do not take like to take coffee in a small hotel. You want to go to 5-star hotel and sit and drink in style. So caffeine, like that, it is very costly compared to the aminophylline. But I don't think there is much advantage. Although some studies show that neurodevelopment is better, side effects are better, but aminophylline is equally good. The disadvantage of aminophylline is that you have to give 2 or 3 times a day, unlike caffeine, which can be given once a day. So if there is a primary cause for apnea, like a metabolic infection, other thing, you have to give specific therapy. Now coming to the next case, a term baby without asphyxia on breastfeeds found to be lethargic and not breathing at 8 hours of life. So when you take rounds, suddenly the parents or the nurse might have noted the child is not breathing. So this is what's called as acute life-threatening event, ALT. This baby was stimulated at 3 years of age. The baby is completely normal and healthy. He never had another attack of similar type. So ALT is defined by the National Institute of Health, NIH, as apnea, the central or obstructive apnea. Color change will be there. Muscle tone, usually hypotonic, or sometimes increased tone may be there. Choking and gagging may be there. The incidence of ALT may be as much as 0.6 to 0.8% among the emergencies who attend in less than 1 year. But in hospital admitted children, it may be higher, almost 2.4 to 2.5%. So you have to differentiate between SIDS and ALT SIDS or sudden infant death syndrome usually occurs in the early mornings or in the night, whereas ALT usually occurs during daytime. The age group is different. In SIDS, it's usually little older infants, whereas ALT is in younger infants, less than 2 months. And males are more affected by SIDS, whereas females more in the ALT. And birth weight also, most of the ALT babies are AGA term babies, whereas SIDS may occur more often in preterm, low birth weight babies. And in majority of the cases of ALT, you may not find any cause. Almost 50% may not have a cause, but you should look for cause like a GE reflex, pertussis or respiratory infection, sudden onset of convulsion, infection, etc. may be there. So in a case of ALT, always look for some cause, try to treat if there is a cause. If there is no cause, then of course, whether it needs to be monitored or not, you have to see. Even after exams, you don't find any cause. If it is a mild attack and the child immediately recovered, you may not have to hospitalize children. It can be observed as outpatient. But if it is a small baby and prolonged resuscitation, better to observe the baby. And this baby need to monitor for some time and see whether it recurs. Because if it recurs, there should be definitely there should be some other cause. In Western countries, many babies are put on home monitoring, but it causes unnecessary, sometimes false alarm in as much as 90% of the cases. So, risk factor for recurrence in ALT is if the baby had apnea for prolonged time, if there was infection or convulsion in preterm and low birth weight babies. Prognosis in ALT, unlike SIDS, is very good. SIDS, baby is sick and they may lose the baby. And there is a risk of recurrence in ALT, although it's less. And most of these infants are developmentally normal. They will be completely all right after that. In long service, we see some cases, not that common, but it is there. Now, going to the next case, a term healthy baby noted to have icterus. Icterus is a common problem, jaundice. Almost 75% of the newborns, preterm newborns, and about 60 to 65% of term babies will have visible jaundice. But the problem comes whether to treat the baby or not. It also depends on whether the risk factor is there or not. So when the jaundice appears on the first day of life, always it is dangerous because it's likely to go for severe jaundice and cause brain damage. So you should be very, very careful. And if it persists for a long time, usually about 2 weeks may be all right. After that, if you continue, you need to investigation. And any baby with jaundice has got anemia or hepatosplenomegaly or edema, you have to obviously investigate and treat. Similarly, direct bilirubin. Normally, direct bilirubin should not be more than 10% of the total bilirubin or less than 2 milligrams per cent. If it is more, it indicates there is some other problem in the baby. Obviously, it may be a neonatal hepatitis or biliary atresia or some other cause. So, that obviously needs investigation. This is a baby with the jaundice. We know the chromosomal. Fortunately, we can clinically diagnose all the mild cases which request treatment, which do not require treatment. Always serum bilirubin is not needed unless the baby has got more risk. So if it in the face, it may be 4 to 8, then gradually involved with the periphery, it is more. The facial skin is highly vascular, very thin, very fat. So mild jaundice will be seen in the face. Severe jaundice extend into the palm cells will be more risky. So a mother who is Rh negative, usually, as you know, the first baby escaped, but always you should be careful because the mother might have been already sensitized by a previous transfusion or abortion. Mother with O positive has more likely to have jaundice. If the previous sibling had significant jaundice required treatment, also you have to be careful. And any hemolysis, evidence of hemolysis like hepatosplenomegaly, anemia, or the baby has got any evidence of infection or poor activity, difficulty feeding, you should be careful. And of course, G6PD deficiency is not very common in this part of the country, but still you should keep it in mind. any other cause of hypervolemia. All these babies, you should be careful. You are familiar with this Bhat's curve risk stratification we can do. Hourly bilirubin, you do the bilirubin, serum bilirubin, and put it in the normogram and see whether baby falls in which risk category, whether it's a minimal risk, low risk, or high risk, because that helps you in managing the baby, whether the baby can be discharged or not, whether to be kept in the hospital for some more time. It will tell you. So any newborn with significant jaundice should have the baby and mother's blood group, because that will tell you whether there is any incompatibility. And similarly, direct Coombs test can be done. And if it's significant jaundice, you need to repeat the bilirubin and follow up how it is rising, and always monitor for any abnormal neurological signs. But once the abnormal neurological signs is often late, because connectors, once it develops, it is not reversible. Mild early connectors may recover with some minimal deficit, but once it develops, brain damage occurs, it is not reversible. So you should be very, very careful. Treat the baby early if it requires phototherapy or exchange transfusion may be done as per the bilirubin level and risk stratification. So you have the charts where you tell you whether you need to do phototherapy or exchange transfusion. Generally, basic rule you remember: 5 milligram below the exchange transfusion level will be the indication for phototherapy, and it should be continued till the risk is over. And if you look at the baby's weight, divide by 100, that will be the upper limit of bilirubin that you can permit. Like a 1000 gram baby, upper limit may be 10, whereas 2000 grams, it will be 20. But if the baby is 4 kilo, it does not make it 40. It will still remain 40. The upper limit remains as 40. So roughly, you divide the weight of the baby by 100, and that will be the upper limit of bilirubin in milligrams. Generally, it's a general rule, but always exception will be there for general rule. This is a baby who has developed connectors. With the effective management and proper treatment, connectors should not develop nowadays, but sometimes it does happen because the mother may bring the baby late, some problem may be the baby under photo. Now, another important problem may be convulsion in a baby, but you must remember almost half of the convulsion newborn babies, or 50%, are subclinical. They may have just stoppage of respiration. They may have alteration in their heartbeat, or they may have apnea, color change. So something may be there. It may not be recognized as convulsion by parents and even sometimes medical personnel. Focal, clonic, tonic, myoclonic colonies, of course, will be visible. So you should also look for convulsion which are subclinical, because sometimes they may require treatment. Sometimes detritus is confused for convulsions. So this is much more common, but does not require treatment. But sometimes the baby may be hungry, maybe glucose may be little low, calcium may be low, that type of problem, or it may be just normal. But it is faster. The movement in a detritus is a very fast movement, and the moment you hold the hand, shake hand with the baby, it will stop, and you look at the baby. If he fixes on your face, or there is no staring, usually the fixation, visual fixation normal, you should think it is a detritus. It does not, you only request reassurance. And in our setup, even today, hypoxia is one of the most important cause of convulsion, maybe except in hospital where there is a good antenatal care and follow-up to the babies. So in the first 24 hours, if the baby develops convulsion, always think of either hypoxia or congenital malformations in the brain. So this requires investigation. Second day convulsions, always think of metabolic causes. Third day, it's intracranial bleed. And after 3 days, always rule out infection. This is a general rule, but always there will be overlap. Sometimes inborn metabolism and other epilepsy type of symptoms also can occur. Though they are individually rare, when you add up, it becomes a very large number. So don't miss this condition. Though rare, in a large hospital with a lot of deliveries, they may be common. So any baby who is sick, ABCD comes, airway, breathing, circulation, sometimes medication may be there. And if there is a metabolic disturbance, always correct that, because if there, so usually we give glucose, then we give calcium after taking the blood, of course, because we do not know whether it is really abnormal. Maybe start treating them on a presumptive basis. Hypocalcemia is less common than hypoglycemia. Hypoglycemia is much more common, but almost half of them may be asymptomatic. They may not manifest clinically. So any high-risk baby should be monitored for glucose, and if even subclinical hypoglycemia may have to be treated, because prolonged hypoglycemia can cause brain damage. Now the question comes whether to give phenobarbital, phenytoin. Any books anywhere you read, they will say phenobarbital to be given. It's an old drug, well-tried drug, and yeah, it is a very safe drug because therapeutic margin is very wide. But the problem comes when the baby is not having good respiration or too much of difference. Then I always suggest phenytoin is better in those cases. If the baby is irritable, good active, then use phenobarbital. If it is depressed, either respiration or activity, phenytoin you should prefer. There is no study which says that phenytoin is inferior or phenobarbital is superior in long-term studies. Although we are often using phenobarbital. One can add one drug to the other also if it is not responding. But majority of the neonatal convulsion may not require anticonvulsant. If at all they require also, before you discharge, you can stop. So only in a situation where multiple attacks were there were neurological abnormalities are there, or strong family history of convulsion is there, or EEG is persisting abnormal, then you need to continue anticonvulsant. Otherwise, no need to continue anticonvulsant for a long time. Either you may not give, or if you give, you can stop. But of course, meningitis requires sepsis. Without meningitis also can cause convulsion in newborn. You have to be treated. Now, next we'll take up the abdominal issues. You may have a baby with not passing meconium. Almost 10 to 12% of the babies will pass meconium before birth, or amniotic staining of meconium. Meconium staining of amniotic will be there in almost 10 to 12% of all deliveries, but it does not cause problem in majority of the cases. Only 10% of the thick meconium stain will get aspirated, causing problem in the baby. Majority of them do not cause any problem. But if it does not cause meconium, even after 4 hours, you should be very, very careful. There could be multiple causes. Intestinal atresia has to be excluded first. Of course, it could be due to hypothyroidism or congenital megacolon, or could be other causes. So you have to be careful. If there is abdominal distension or vomiting, then of course, all the more we should be careful. If the baby is having feed intolerance and poor feeding, rectal feeding, especially if the baby is preterm, you may be dealing with the case of NEC. I will not go into the details of that because it will take another 1 hour to discuss. But remember, your resuscitation is not complete unless you make sure upper and lower intestinal tracts are patent. So you pass a catheter sometimes to the stomach, not only to rule out esophageal atresia. If you aspirate more than 20 ml of gastric aspirate in a term baby, it is also abnormal. It indicates upper intestinal obstruction. Sometimes duodenal atresia or jejunal atresia and aspiration to the stomach content may help in diagnosis. Now, next case, a preterm baby was on breastfeeds, present with the poor feeding and poor activity. Obviously, you should consider sepsis in this case. Lethargy, poor sucking, especially in infant who is preterm, is a danger sign. And if there is a risk factor like fever, foul smelling, like a prolonged rupture of membrane before delivery, all the more sepsis is likely. So you should check the temperature, look for umbilical discharge, you look for convulsions, blood sugar, any bleeding, spots, all this have to be examined. And you have to see when the baby is able to feed. If the baby is not able to suck or feed, it is one of the danger signs. So you have to, again, comes to ABCD, you feed if there is shock, correct respiration color, heartbeat, everything, ABCD. And if there's convulsion, of course, we will give anticonvulsant. Any metabolic problem is maybe associated along with that. Hypoglycemia is quite common. You remember in newborn with sepsis, not always hypoglycemia occurs. Sometimes hyperglycemia also occurs. Both are dangerous, hyper and hypoglycemia. In a newborn, hyperglycemia and hypoglycemia both could be dangerous, may cause apnea and problem. And you should provide appropriate warmth and start treatment as per your policy, because you must be best knowing what organs are common, what is the sensitivity pattern. You may use the antibiotic appropriately. But you can change the antibiotic if the culture comes something else. Always give fungal care, keep the baby warm. Now, temperature control is one of the very, very important things. Even in warm climate, term babies in summer newborns can develop hypothermia. Never ever use core body temperature for routine monitoring. I'm saying routine monitoring. Always take the surface body temperature, because our aim is to prevent hypothermia, not treat hypothermia. We should pick up babies who requires temperature support, not treating hypothermia, because it is sometimes late. So you give kangaroo care, warm, covering the baby, or sometimes warmer, incubator, all these things we may use. You should not only train yourself, but also train the mother and health worker to record the temperature even without thermometer. Everybody may not have a thermometer. So if the baby's body is warm, but periphery is cold, he is having cold stress, he needs to be covered, kangaroo care, provide warmth. If the abdomen and chest also have become cold, that means he has already developed hypothermia, you have to warm the baby. Never use hot bottles or anything directly can come in contact with the baby, because you will produce scalds and burns. You should be very, very careful. There is no role for hot water bags and other things in the modern day practice. Now, one more condition I will take up is a bleeding unit. Bleeding unit is a common problem. One of the commonest causes may be hemolytic disease of the newborn due to vitamin K deficiency. Now we routinely recommend vitamin K prophylaxis for all newborns, irrespective of term or preterm. They should receive prophylactic vitamin K. But sometimes the baby, the fetus might have lost blood even before delivery. A baby looks pale. He has got poor pulse. There could be an APH or a quad bleeding by mistake, or it may be some other hemolytic blood loss may be there. So you should, sometimes it may happen even before the baby is born. He might have lost blood and he may require transfusion. So always carefully look for that. But if the baby is bleeding, irrespective of whether it's bleeding due to vitamin K deficiency or not, always give vitamin K. If the baby is active, healthy, feeding, breathing, either it is due to vitamin K deficiency or some problem with the platelets. Either the platelet count is low due to some reason, or it could be some autoimmune problem. So some problem in the platelet level. Remember, coagulation disorder do not present immediately after birth. They take time. Even less than 5% of the normal coagulation factor is sufficient to prevent spontaneous bleeding. They may bleeding when you cause a needle or something, you cause injury, they may bleed. But otherwise, normally they will not bleed. So you should be very, very careful, because this baby has got very severe bleeding. You should remember these words, the misfit. So each mnemonic for the problem, a child who is sick, it may have trauma, it may have hypoxia, hypovolemia, or heart disease. It may have some endocrine problem, congenital adrenal hyperplasia or hypoxia. I have not gone into details of so many causes because it's not possible to cover in 30 minutes. He may have a metabolic problem. He could have an inborn errors of metabolism. Yes, for sepsis, meningitis, pneumonia, UTI. Sometimes formula also can create problems. You have to be very, very careful. Intestinal problem could be there. Toxins like poisons can be there. Naphthalene balls are covered in clothes. Babies kept for a long time, they can cause hemolysis in the baby, especially if they have G6PD deficiency. Yes, for she's. So the word misfit, you remember, mnemonic, you remember, all conditions in the sick baby will be covered in that. So take home message is early recognition and intervention are very, very important. All babies should be carefully examined. What you think as a normal baby may not be always normal. So like inborn, so metabolic, the baby will look hale and healthy for 2-3 days. After that, suddenly he will develop problem. So normal baby does not mean he is completely normal. He is also having risk. So careful examination is very, very important. And medical personnel should be trained to pick up danger signs and follow the baby. Mothers and parents also should be told about the danger signs at discharge so they can bring the baby to the hospital at early stage and identify specific medical problem and treat which will improve the outcome. So I hope that I have finished within the time given to me. Maybe 1 or 2 minutes I have exceeded. It is open for question. Thank you very much.
Sir, thank you, sir. But sir, thank you very much, sir. Thanks for your concise talk. There is a question from Dr. Shogranathan, sir. Like, is there from peripheral smear, how do we differentiate the types of hemolytic anemias, RH, ABO, and all that?
See, peripheral smear completely you will not be able to differentiate because ABO incompatibility and other hemolytic disease, they sometimes may look similar. Like spherocytis is in the newborn, and ABO incompatible look almost similar in peripheral smear. So if there's a family history, that may give an indication. Other thing is that whatever is the cause for the hemolysis, the treatment immediately remains the same, but follow-up will tell you whether what is the cause. So from peripheral smear alone, you will not be able to differentiate. In ABO incompatibility, you will find more spherocytes, whereas in RH incompatibility, the antibodies are much more stronger. So you will not find spherocytes. You will find broken cells and other things rather than spherocyte. Whereas in ABO incompatibility, you will find spherocytes. But congenital spherocytosis and ABO incompatibility, you cannot really differentiate immediately after birth. But you have to keep both in mind.
Okay, sir. So this transcutaneous bilirubinometer, is it being routinely used, sir?
Yeah, so you have to have some screening, maybe who require serum bilirubin level or who do not require serum bilirubin level. So in a milder cases, it is enough. We also have done the study with transcutaneous bilirubin and serum bilirubin. It is fine till the bilirubin goes at about 15 milligrams. After that, the relation is not very direct and it does not really tell you whether about 20 is 30, 40 sometimes does not tell you. So if it goes beyond the risk factor level, you have to do serum bilirubin. But for a screening device, it is good. And also, your all unit may not be equally lighted. So when you look at the baby clinically, you look at good light, background light. Whereas your bilirubin, transcutaneous bilirubinometer will pick up on the skin color irrespective of the environmental light. So it gives a reading directly how much is the bilirubin. So that way it helps you in screening. So definitely it can be used for screening, but it is not enough for continuously monitoring if the bilirubin is higher. Once the bilirubin reaches above the intermediate level, then you have to do serum bilirubin.
Okay, sir. Thank you, sir. So that is a very concise for the general forum. Sir brought out important points, salient points in day-to-day management of newborn problems. So
One comment.
yes, sir.
Yeah, he said the misfits, he mentioned the various conditions. As I mentioned the previous talk, then misfits, THEN, nutrition. Of course, metabolic means nutrition. He has mentioned bracket the electrolyte disturbances. Okay, so that, sometimes metabolic, people think of only inborn as a metabolism. So then